Med History.
Chronic autoimmune lymphomatous thyroiditis, CHAITIS, is a chronic thyroid disease of autoimmune origin. It was described by Hashimoto in 1912. The disease is more often observed in women and is most often diagnosed among the known pathologies of the thyroid gland. Autoimmune thyroiditis is detected in 1 in 10, 30 adult women. 1. The disease in question is of an autoimmune nature, and the presence of antibodies is mandatory for it. Data on the detection of antibodies to thyroid tissue and serum in patients with autoimmune thyroiditis were first published in 1956. Subsequently, it turned out that autoimmune thyroiditis implies the presence of antibodies to thyroglobulin, the second colloidal antigen, and thyroperoxidase, microsomal antigen. Reasons. Even with a hereditary predisposition, additional adverse provoking factors are necessary for the development of autoimmune thyroiditis. Past acute respiratory viral diseases, foci of chronic infection, on the palatine, tonsils, sinuses, carious teeth, ecology, excess of iodine, chlorine, and fluorine compounds in the environment, food and water, affects the activity of lymphocytes, prolonged uncontrolled use of medications, iodine-containing drugs, hormonal drugs, radiation exposure, long exposure to the sun, traumatic situations, illness or death of loved ones, loss of work, resentment, and disappointment. Provoking factors. Today it is generally believed that apoptosis, that is the programmed death of follicular thyroid cells, is one of the main causes of autoimmune thyroiditis and other thyroid pathologies. It is assumed that viruses and genetic disorders contribute to the initiation of apoptosis. What is the danger of thyroiditis during pregnancy? Autoimmune thyroiditis in a woman does not affect the possibility of becoming pregnant and having a healthy child, provided that the patient has a normal hormone level, thyroid-stimulating hormone, TSH, up to 2.5 med-L, including in the first trimester of pregnancy. With hormonal disorders, the following complications are possible: placental insufficiency, miscarriage, premature birth, sleep problems, late toxicosis, pregnancy fading, bleeding after childbirth, fetal hypoxia, neonatal thyrotoxicosis. Symptoms of autoimmune thyroiditis. Most cases of chronic autoimmune thyroiditis, in the euthyroid phase and the phase of subclinical hypothyroidism, are asymptomatic for a long time. The thyroid gland is not enlarged in size, it is painless on palpation, and the function of the gland is normal. Very rarely, an increase in the size of the thyroid gland, goiter, can be determined. The patient complains of unpleasant sensations in the thyroid gland, feeling of pressure, coma in the throat, mild fatigue, weakness, joint pain. The clinical picture of thyrotoxicosis in autoimmune thyroiditis is usually observed in the early years of the disease, has a transient character, and as the atrophy of the functioning thyroid tissue passes for a while into the euthyroid phase, and then into hypothyroidism. Postpartum thyroiditis, usually manifested by mild thyrotoxicosis at 14 weeks after delivery. In most cases, fatigue, general weakness, and weight loss are observed. Sometimes thyrotoxicosis is significantly pronounced: tachycardia, feeling of heat, excessive sweating, tremor of the extremities, emotional lability, insomnia. The hypothyroid phase of autoimmune thyroiditis manifests itself at the 19th week after childbirth. In some cases, it is combined with postpartum depression. Pain-free, silent thyroiditis is expressed by mild, often subclinical thyrotoxicosis. Cytokine-induced thyroiditis is also usually not accompanied by severe thyrotoxicosis or hypothyroidism. The pathogenesis of autoimmune thyroiditis is associated with T lymphocyte clones and hereditary predisposition. The development of a chronic disease requires exposure to exogenous factors, such as infections and pharmaceuticals, that activate T lymphocytes and trigger a chain reaction. T cells, cooperating with antithyroid antibodies, attack thyroid cells, which leads to their destruction and a decrease in the number of functioning units. The number of antithyroid antibodies reflects the degree of the autoimmune process and may decrease over time. To manifest the toxic properties of antibodies, they need to interact with T lymphocytes sensitive to thyroid antigens. Disorders in immunological insensitivity and synthesis of T lymphocyte clones can lead to the formation of autoimmune pathologies, including autoimmune thyroiditis. Complications of autoimmune thyroiditis. Hiatus is a conditionally safe disease that does not lead to complications only if the necessary concentration of hormones in the blood is maintained, that is the euthyroid state, and accordingly, then no complications develop. But with the onset of hypothyroidism, complications may occur. In the absence of treatment for hypothyroidism, complications may occur: impaired reproductive function, marked memory loss, up to dementia, anemia. But the most formidable and severe complication of hypothyroidism, hypothyroid or myxodomatous coma, occurs with a sharp deficiency of thyroid hormones. Diagnosis of autoimmune thyroiditis can be difficult before hypothyroidism occurs. Endocrinologists make a diagnosis based on clinical symptoms and laboratory results. The presence of autoimmune disorders in other family members may confirm the likelihood of autoimmune thyroiditis. Laboratory tests for autoimmune thyroiditis include a general blood test that may show an increase in the number of lymphocytes, an immunogram showing the presence of antibodies to various components of the thyroid gland, determination of the level of hormones T3 and T4, as well as the level of TSH in the blood, ultrasound of the thyroid gland, which allows you to assess the size of the gland and its structure, a fine needle biopsy of the thyroid gland, used in case of suspected malignancy. The criteria for the diagnosis of autoimmune thyroiditis are an increase in the level of antibodies to the thyroid gland, hypothyroidism according to ultrasound results, and signs of primary hypothyroidism. In the absence of at least one of these criteria, the diagnosis can only be probabilistic. Therefore, it is important to take into account the totality of clinical data and research results for accurate diagnosis and subsequent treatment. What tests are needed to determine AIT? To establish autoimmune thyroiditis, it is necessary to donate blood for thyroid-stimulating hormone, TSH, thyroxine-free, T4-free, and antibodies to thyroperoxidase, TPO. If antibodies to TPO are elevated, but TSH is within the normal range, then the diagnosis of AIT is likely. It should be noted that when a patient is diagnosed with manifest or stable subclinical hypothyroidism, the diagnosis of autoimmune thyroiditis is important to establish the cause of a decrease in gland function. But despite this, the diagnosis does not change therapeutic methods in any way. Treatment consists in the use of hormone replacement therapy with thyroid hormone preparations. The use of a puncture biopsy of the thyroid gland is not indicated for the establishment of chronic autoimmune thyroiditis. It should be performed only if there are nodes of the thyroid gland more than 1 centimeter in diameter. It is important to note that there is no need to monitor the number of available antibodies to the thyroid gland during the disease, because this procedure does not have a diagnostic role for analyzing the progression of autoimmune thyroiditis. The prognosis for the development of autoimmune thyroiditis is usually favorable. With timely initiation of treatment, it was possible to significantly slow down the process of destruction and decrease in thyroid function, achieving long-term remission of the disease. Most patients have maintained satisfactory well-being and normal working capacity for more than 15 years, despite periodic exacerbations of autoimmune thyroiditis. Autoimmune thyroiditis and elevated levels of antibodies to thyroperoxidase, ATPO, are risk factors for the development of hypothyroidism in the future. In women who have had postpartum thyroiditis, the probability of recurrence after the next pregnancy is 70%. Approximately 25–30% of women with postpartum thyroiditis later experience chronic autoimmune thyroiditis, which can progress to persistent hypothyroidism. For prevention, regular monitoring of patients with diagnosed autoimmune thyroiditis without thyroid dysfunction is recommended in order to timely identify and compensate for the manifestations of hypothyroidism. Women who have elevated levels of antibodies to thyroperoxidase without changes in thyroid function are at risk of developing hypothyroidism during pregnancy. Therefore, it is important to monitor the condition and function of the thyroid gland, both at the beginning of pregnancy and after childbirth.